Okay, let us continue from where we left last time. We are discussing dyspepsia. Dyspepsia is a very important area where we need to evaluate properly and use an algorithmic approach so that the first step of investigation would be, does the patient have alarm signs? Alarm signs are what? Alarm signs are mad blow, mass in the epigastrium, A, anemia, D, dysphagia, BL, blood in the upper or lower GI tract, LOW, loss of it. First and foremost thing is when the patient comes with 4 weeks of upper abdominal dyspeptic symptoms, my emphasis would be to know whether the patient is having any dangerous condition or a simple ordinary dyspepsia. For that, I have to separate them into those with alarm signs, those without alarm signs. Supposing there are no alarm signs, then I have to look at the age of the patient. If the age of the patient is more than 55, again he is qualifying immediately for endoscopy. Alarm signs patients are qualifying for endoscopy. All others, we can do treatment on an empirical basis. That means patients who do not have alarm signs, who are less than 55 years of age, they can go for uninvestigated dyspepsia treatment on an empirical basis. So there are no alarm signs and patient is less than 55. Then you can start treatment empirically, uninvestigated dyspepsia, or test for H. pylori and treat them. That means test and treat or treat and test. Both are available in the protocol. Now let us go for the third step. Third step is, if the alarm signs are present, then suspend all NSAIDs. There are two qualifications for upper GI endoscopy. One, alarm signs, the other is more than 55. If he is more than 55 or has alarm signs, first thing you have to do is suspend NSAID. Review all medications and exclude the ulcerogenic medications. Then immediately order the upper GI endoscopy and classify the dyspepsia. Usually endoscopic reports are not written in this format in which we want. They will say there is gastritis, pangastritis, there is no mucosal thickening, all those descriptive ways they will write. But you have to ask the endoscopist to classify the dyspepsia into the following categories as per the international guideline. Go back to him, sir, you have written this report. Does it fit into any one of these things? What are those things? And let them have a practice of doing that. Okay. The fourth step would be upper GI endoscopy. There are 4 or 5 conditions important. Non-ulcer dyspepsia. You should write the diagnosis. Non-ulcer dyspepsia. There is no ulceration. Or it is chronic gastritis picture. Second. Otherwise, GERD picture or hiatus hernia like thing. The fourth one is there is an ulcer, gastric ulcer or duodenal ulcer or both, but peptic ulcer. Or there is an adenocarcinoma or any other type of tumors that see. In addition, miscellaneous findings, not fitting into dyspepsia, but they may find some nodularity, they may find some diffuse inflammation, they may find some polyp, they may find some sort of, varicosities, and rugosities are increased, motility is decreased. All those are miscellaneous findings. So they can comment on that. It appears to be dilated and decreased motility. Rugosities are more, or the stomach is having no rugosity and like a paper, as in case of B12 deficiency, anemia, like atrophic tongue, atrophic gastritis will be there. Or there could be varicosities will be there. These are additional findings, they have to write. But basically, the endoscopist is expected to write the diagnosis in the following 4 or 5 headings. One, non-ulcer dyspepsia. Number two, chronic gastritis. Number three, GERD or hiatus. Number four, ulcer is there, gastric ulcer or duodenal ulcer, or there is a mass or tumor suggestive of gastric cancer or duodenal cancer. We have seen these things last time. Now, this I wanted to dilate a bit on this mechanism. See, there is what is called lower esophageal sphincter. Normally, what will happen is the stomach is like a bag, mixie, where you put something, switch on, exactly that's what it does. Mixie runs for 1 or 2 minutes, this runs for 2 hours. Slowly, the stomach peristaltic movements contract the stomach and then make sort of the digestion possible of all the contents there. For that, it requires acid, it requires pepsin, and requires peristaltic contraction. Supposing you want to churn anything, upper part should be closed, lower part should be closed. Upper part is gastroesophageal sphincter, lower part is the duodenal sphincter, gastroduodenal sphincter. So these are tight, and the stomach is contracting during the 1.5 hours, 2 hours of time. Once everything is ready, then the lowest duodenal sphincter will open, and then the stomach contents will pass into the duodenum. This is the mechanism. But during this process, what happens is certain gases come because of the digestion. So some certain gastric gases will be formed. These gases have to escape. They can't escape down because duodenal sphincter is closed. The gastric esophageal sphincter will have to open. This is what is called TELS, transient TR, relaxation of esophageal sphincter. TRES, transient relaxation of esophageal sphincter. This happens everyone, even when for us also, in the every 5 to 8 minutes, the esophageal sphincter slightly relaxes, so that whatever gases are there, they escape, and we brave, mimic, or may not. What happens in people who have gastroesophageal reflux is this TRES, transient esophageal relaxation of esophageal sphincter. The frequency of that number of times it is opening has become more. That means every minute or every half a minute it opens. And also the duration for which it is opening is more. With the result, not only the gases occasionally, but the stomach contents themselves will reflux into that. Not that the esophageal sphincter is thrown open permanently. It is only the normal mechanism of transient relaxation of esophageal sphincter, which is exaggerated in terms of frequency and duration. With the result, there is gastric. Then what is wrong? Let it come into the esophagus. No, gastric contents are acidic. Esophageal mucosa is not tuned to receive acid. Once the acid contents come here, they produce damage to the esophageal mucous membrane. Means what? Acid digestion starts taking place there into the lower, and then metaplasia starts. Then the columnar epithelium of the esophagus is replaced by the squamous epithelium of the stomach, which is now the Barrett's esophagus, which we have seen last time. So this GERD reflex is what we have to do is, you can see here as this one, the acid contents, stomach contents are refluxing into the lower esophagus. Now, then what happens is, this is the columnar lined distal esophagus is now seen. That has come, and that is called the Barrett's. The problem with Barrett's is not only it produces epigastric pain, burning, and discomfort, and dyspepsia, it is a precancerous condition. This can lead to adenocarcinoma, the esophagus. So that is why you should not allow a patient of GERD to develop Barrett's and then go on to adenocarcinoma. So we have seen the treatment aspect also of the GERD last time. Now we also discussed about the urea breath test also. Last time we have discussed that. Now we will go further into the H. pylori now. H. pylori testing also I have shown you earlier, but I am just repeating for the sake of H. pylori testing. There are three types of tests, as I told you: UBT, urea breath test, fecal antigen test, and serology. Of the most commonly available acceptable test is fecal antigen test, or testing the gastric aspirate for evidence of H. pylori. H. pylori is a bacterial infection. Now we go to the H. pylori part. We have treated the peptic ulcer last time. We finished. Yeah. Helicobacter pylori is a gram-negative, spiral-shaped flagellate bacilli. It is a bacterial infection, gram-negative bacterial infection. Route of transmission is waterborne. Just like your salmonella, just like your shigella, it is a waterborne disease. So the disadvantage of being a waterborne disease is you treat today, again he gets contaminated water, again H. pylori comes back. So it is a problem is recurrent H. pylori infections are possible. So what will happen? H. pylori infection, weeks and months will pass, chronic superficial gastritis, then it takes years and decades, then it can pave way for peptic ulcer disease, or it can produce chronic superficial gastritis, or it can trigger lymphoproliferative disease, or it can go for chronic atrophic gastritis, which can finally lead to adenocarcinoma. So that means what? H. pylori is not a benign condition. It must be identified and treated, because it can lead to PUD, it can lead to chronic gastritis, it can lead to lymphoproliferation there, it can lead to atrophic gastritis, can lead to adenocarcinoma. It doesn't happen in 1 week or 15 days or 6 months. Over the years, if H. pylori is left untreated, it can go on like this. So how do I treat the H. pylori? All of you know, it is combination therapy is the rule. You have to eradicate H. pylori, is essential, and also prevent recurrence by advising safe water drinking practice. So he should always wash his hands before taking food and after visiting toilet, and use only safe water, and any hot and readily cooked food and not stored food or contaminated water. So ulcers do not heal if the infection persists. One cause of non-healing peptic ulcer is coincidental concomitant H. pylori infection. If you treat H. pylori, the ulcer will then heal. The regimen contains what is called full dose PPI, two times a day. Full dose PPI is 40 milligrams of omeprazole or 20 milligrams of esomeprazole, or 40 milligrams of pantoprazole is full dose. That should be given twice a day, okay, for 2 weeks. Clarithromycin 500 milligrams BID, or metronidazole plus metronidazole or amoxicillin. If you want to give amoxicillin, it is written here 1 gram. In adult more than 50 kilos, you have to give 2 grams, less than 50 kilos, 1 gram BID. So if the body weight is more than 50, you have to give 2 gram BID, less than 50, 1 gram BID, metronidazole 400 milligrams BID, clarithromycin 500 milligrams BID, double dose, full dose twice a day. This is available as compliance packages of combination packages. You can use any one of the HP kit or any other combination packages. This is a standard question, short notes question. Discuss the causes of non-healing peptic ulcer disease. Short notes. What are the? You have a patient who came with dyspepsia, you identified ulcer disease, you ruled out H. pylori, or you treated H. pylori, and you have given him full dose of PPIs for a required length of time, say for about 4 weeks or 8 weeks, and then still the ulcer is not healing. Then what are the conditions? You should know. What is non-healing ulcer? A properly identified peptic ulcer, either gastric or duodenal, which is treated for 4 to 8 weeks with full course of anti-ulcer medications, as we know, and we have taken care of H. pylori also. Patient did not respond to the treatment. Ulcers are not healing. What are the causes? First thing is he's continuing smoking. If the smoking is not stopped, smoking, as I showed you, it is ulcerogenic in more than one way. It increases the bicarbonate of the pancreas. It decreases the bicarbonate secretion and the intestinal tract. thereby acid neutralization is not there. It increases the prostaglandins, which increase the ulceration, and it interferes with the mucosal defense mechanism and also the blood supply to the mucosa. For these reasons, smoking is detrimental to the whole system, most of our healing of ulcer. Or he has taken the prescription, but he has not purchased or not taken the medicine. Non-compliance with medication, smoking must be excluded. Supposing we know that he's strictly taking medicines, he is not a smoker, or he stopped smoking, still the ulcer is not healing, ulcer turning malignant could be the reason. That means ulcer has become malignant ulcer. You may require a repeat biopsy and then repeat endoscopy and biopsy. Ulcer turning malignant will not heal. Or the H. pylori that was you have detected, you have treated with 3 drugs, but it is resistant H. pylori. So today, bismuth subcitrate and several other regimens are coming. If you just browse, you can see current treatment of H. pylori is slightly modified compared to the previous standard treatment which we all practice. So that is for resistant H. pylori. Or false positive H. pylori, you are thinking it was a H. pylori is positive, you have put him on treatment and it is not responding. There may be other missing causes. Another thing is, he is continuing to use NSAIDs which are ulcerogenic. Other ulcerogenic drugs and NSAIDs are being used with the result the ulcer is not healing. These are the 4 common causes. Non-compliance with medication, continuation of smoking, ulcer turning malignant, H. pylori not not responding and resistant, and false positive H. pylori. Empirically, you have treated for it, and inadvertent use of the concomitant NSAIDs and ulcerogenic drugs. The rarer causes are Zollinger-Ellison syndrome, MALT, mucosa-associated lymphoid tumors, and then Crohn's disease and MEN1, multiple endocrinopathy 1. Sometime we will discuss multiple endocrinopathy. Then you will come to know about MEN1 and MEN2. 2 types are there. I will tell you one day about that. So the rarer causes are JD, MALT, Crohn's, and MEN. Okay. Now we come to the functional dyspepsia. What is functional dyspepsia? There is no ulcer, there is no gastritis, there is no tumor, there is no chronic gastritis also. Absolutely normal endoscopy. But the patient is continuing to have dyspeptic symptoms. That means it is a behavioral disease rather than gastrointestinal problem. Now, today's world, the functional dyspepsia is increasing day by day because of the associated lifestyle problems and also associated disturbances of mind that occur in the society due to various reasons. Functional disorders are on the rise. Likewise, functional dyspepsia is also concomitantly rising. How do you treat them? Of course, lifestyle modifications. What is lifestyle? Lifestyle is reducing the weight, stopping the smoking, stopping hallucinogenic drugs, and then patient not immediately lying down after food. At least 2 hours after food, he has to be in the erect position and preferably sleep in a slanting position on the left lateral side with the 2 pillows under the chest. These are the functional measures. And reducing obesity. So these have to be practiced. In addition, behavioral treatment, cognitive behavioral treatment, suppress the acid with prokinetics probably, and also antidepressant medications also you have to use. Here is the role for antidepressants like bupropion or any other Fludac or any other SSRIs, serotonin, selective serotonin reuptake inhibitors like sertraline and any other drugs you can use. Sertraline, fluoxetine or Fludac, and then bupropion, other antidepressant drugs, or even amitriptyline, nortriptyline, any of these antidepressant drugs should be used. Generally, anti-anxiety drugs are not useful. Like, alprazolam or other zolams, they are anti-anxiety drugs. They're not useful because Functional dyspepsia is more associated with depression and not with anxiety. Okay. Suppose somebody has got chronic gastritis. That means endoscopist has reported CG as the diagnosis. What do? Is it atrophic gastritis? Then pernicious anemia. Chronic gastritis is due to pernicious anemia. You have to take B12 estimation. If the B12 is lower, it is pernicious anemia, the atrophic gastritis. Then you have to do PCA negative and then IFA negative. Intrinsic factor antibody and then parietal cell antibody. PCA is parietal cell antibody, IFA is intrinsic factor antibody. So you have to classify them: PCA negative, IFA negative, PCA positive, IFA negative, or PCA positive, IFA negative, both positive. If both are positive or PCA is positive, at least it is pernicious anemia. Atrophic gastritis, IFA is always negative. If the intrinsic factor antibody is negative, it is not pernicious. So intrinsic factor antibody should be positive, or PCA should be positive, or both should be positive. PCA is parietal cell antibody, IFA is intrinsic factor antibody. This has to be done in any case of chronic gastritis, and B12 estimation has to be taken care of. So what are the medications I should be looking at to prevent ulcer reoccurrence and ulcer faster healing? One, NSAIDs means low dose aspirin is not contraindicated. 75 milligrams of aspirin as a cardioprotective and antiplatelet agent must be continued, and it need not be discontinued. This you have to keep in mind. Otherwise, anybody with the chronic dyspepsia, you must stop aspirin and you will endanger the platelet function there. Steroids, oral steroids are not indicated and should be stopped. Inhalation steroids like Budecort or anything that he takes on inhalation route, there's no problem. All theophylline are ulcerogenic. So if he's taking delphylline retard or any of the zebrofilin, better you stop. Bisphosphonates, which are used to increase the calcium deposition in the bone and help osteoporosis, are known to cause ulcers. Calcium channel antagonists, like your nifedipine group of drugs, they are also ulcerogenic. Anticholinergics also are. What do? Immediately suspend the medicine, or you reduce the medicine to a minimum required dose. Or when NSAID is a must and the pain is so bad, you switch from conventional NSAIDs to selective COX-2 inhibitors. Selective COX-2 inhibitor is celecoxib, celecoxib. These are the selective COX-2. What is COX-2? COX-2 is an enzyme which is there in the stomach as well as in the other tissues. This COX-2 inhibits the prostaglandins, thereby it will be helping the pain. Here, in the stomach, prostaglandin suppression leads to increase in the ulcer formation. Okay. Now what do? I use a selective inhibitor which does not attack the COX-1 in the GI tract, and only it selectively the joint COX-2 only is inhibited. So much so the ulcer promotion, ulcer intensification is not there with these drugs. Okay. What are the future therapies? Potassium competitive acid blockers are coming. Cholecystokinin 2 receptor antagonist, anti-gastrin vaccine. Anytime it can come, and anti-gastrin vaccine, a lot of research is going on. For potassium competitive acid blockers, that means the acid is secreted by the H ions into the stomach. So if you use a competitive potassium blocker, potassium is secreted into the stomach in place of hydrogen. So much of the acid is blocked. CCK2 receptor antagonists, they also reduce the ulcerogenicity and acidity. Anti-gastrin vaccine, and then new PPIs like elaprazole is already available, and then tantaprazole is also available. The advantage is the elaprazole is you can use it once a day. You don't have to give twice a day. Tantaprazole you can give it twice a week or even once a week. Tantaprazole even longer acting PPI. H2RAs and OTC medications like antacids are being used left and right, one has to be very careful about the OTC medicines. Immediate release formulations are also approved. Earlier, we used to say you have to give PPI half day, half an hour before food so that the PPI gets absorbed and it will go into the system, come to the stomach and block the acid. And then the food comes. By the time the food comes, the PPA is already in full place for action. So you always prefix around half an hour before food you give PPA. Now today we have got PPAs which are immediate release formulation. You don't have to food, you keep on the plate, take the PPA and have it. So these are particularly esomeprazole is a faster acting drug. So the time gap need not be much there. These are called immediate release PPIs. Now, what are the healing rates when I use different PPIs? You can see in the placebo, the lower line is the placebo, the white line, and the healing rates at the end of 12 weeks, it to the order of around 38 or 40% maximum. Okay, after 12 weeks of treatment with H2 plus 12 weeks of general measures without giving any H2RAs or PPIs, only around 38% people will have remission of symptoms on their own. That is the placebo. Then next is the H2RAs, ranitidine, famotidine, cimetidine group of drugs. If these are used, up to around 60% of people get relief around 12 weeks. When you use PPIs, you can see almost 95% of the people get the relief at the end of 12 weeks. So PPIs are way above the other measures, general measures, followed by H2RA, followed by PPIs. PPIs are better. This slide you need to understand very thoroughly because this is the mechanism, acid suppression theory. You see in the center, you're able to see that parietal cell. The central one, the egg-shaped cell, is the parietal cell. In the parietal cell, that sort of fluid one is called the canaliculus. Into the canaliculus, the acid is secreted from the parietal cell. Parietal cell has got the capacity to secrete the acid, and that gets into the canaliculus, and through the canaliculus, it is poured into the stomach. What are the triggers or stimuli for the parietal cell? You can see histamine is a positive stimulator. Plus means stimulator. On this side, you can see histamine stimulates the parietal cells to produce more of acid. Okay. The other side, you have vagus is there. Vagus secretes acetylcholine. This acetylcholine is also a potentiator of acid secretion. That is why anti-acetylcholine agents like atropine or parasympatholytic drugs are useful in the treatment of acid disease to some extent. Okay. There is another way that the acid is secreted. The stomach has got the gastrin, the G cells are there. The G cells are called the stomach gastrin secreting cells. The gastrin secreting cells empty their gastrin into the blood vessel. Through the blood vessel, the gastrin reaches the stomach, and the gastrin, two ways it acts. One way through the ECL cell, the other way directly onto the parietal cell. Through the ECL cell, it will go to the ECL cell and stimulate the histamine. Through the histamine, the acid or gastrin directly has got an effect on the parietal cell. Now, we have got another cell called the D cells. So, these D cells produce a substance called somatostatin. Somatostatin is inhibitory to histamine, thereby acid is reduced. Or likewise, somatostatin directly also inhibits acid secretion. So that means what? There is an acid secreting mechanism, there is an acid inhibition mechanism. Somatostatin is acid inhibitory, and then are like acetylcholine is stimulatory, histamine stimulatory, and gastrin is stimulatory through the histamine. The histamine by directly onto the parietal. So for all these things, the final common pathway is secretion of hydrogen ions into the canal. There is an enzyme called HKATPase. Okay, this HKATPase enzyme, it makes the substitution of potassium to hydrogen and makes the hydrogen into the canaliculus. The acid is increased. Now, what you are doing? This is called the proton pump. Proton pump is that HKATPase, and you are go and interfere with the HKATPase. So much so potassium is secreted in place of hydrogen. So much less of acid is there. This is the final common pathway in the tubular vesicles, the proton pump or HKATPase. So proton pump inhibitors work directly to that. That is why acetylcholine is attacked. It has to go through the proton pump. Histamine go through the proton. Gastrin either directly or through the histamine, again proton pump is required. And somatostatin for itself has to negative effect, and again it has to influence the proton. But suppose you go and block the proton pump by yourself directly with the drug, these drugs, whatever mechanism the acid is coming in, they block it. So these are the final common pathway blockers. That is why the proton pump inhibitors now have revolutionized the treatment of this. So which PPI I should take? This is common: pantoprazole, lansoprazole, omeprazole, rabeprazole, esomeprazole. Now, what is more important is, what is the gastric pH more than 4 is protective. Less than 4 is harm. Less than 4 is acidic. More than 4 is less acidic. Okay. So you have to keep the intragastric pH more than 4. How many hours my drug is able to keep the intragastric pH above 4? That is the question. You see, pantoprazole 10.1 hours. So you have to give BID. Lansoprazole again 11.5 hours. Omeprazole 11.8 hours. Rabeprazole 12.1 hours. Esomeprazole once a day you give. Rabeprazole also once a day. So if you give once a day, all these drugs, these are generally pantoprazole, lansoprazole, omeprazole, rabeprazole have to be given twice a day for them to be effective. But esomeprazole, because of its relatively longer life, even once a day might also work. So very important for information for us. Now, points to remember in dyspepsia, which you should not forget. If you are asked to get up from sleep, these points must be there. 1, I should not forget to look at the alarm signs. What are alarm signs? Mass, anemia, dysphagia, blood, loss of blood. Age of the patient should always be taken into consideration. Then, uninvestigated empirical treatment for uninvestigated dyspepsia only if the age is less than 5, if there are no alarms. Uninvestigated treatment for 8 weeks, not responding, you test. Peptic ulcer disease should be excluded. H. pylori test should be done. If it is positive, treat with the conventional 3 drugs for 2 weeks. Eradicative treatment must be given. GERD is there. You have to give double dose PPI for 6 to 8 weeks along with prokinetics. In no other condition, prokinetics are required. Unless there is GERD, unless there is gastroparesis, unless there is diabetic gastropathy, unless there is hiatus hernia, prokinetics like your domperidone and group of drugs are not indicated. Don't left and right prescribe PAN-D or etioprazole combined with rabeprazole. All these combinations we avoid. Plain omeprazole, plain esomeprazole, plain rabeprazole only use. There is an indication like GERD, hiatus hernia, gastroparesis, diabetic gastropathy, but you are justified, or even functional dyspepsia, you are justified in using GERD. Otherwise, you are justified in using the prokinetic. Otherwise, no. No long-term PPI treatment for 5 years, 10 years, like that. So you can give for 6 to 8 weeks, 10 weeks, and then give a gap. And again, PPI on demand. That means you can empower the patient, keep a supply of PPIs after 8 weeks. And then whenever you feel the symptoms, you can take on demand for 1 or 2 days. NSAIDs are important. Change over to COX-2 inhibitors rather than conventional NSAID. If not responding, review your diagnosis, review all the drugs, repeat endoscopy only for peptic ulcer, for chronic gastritis, for non-ulcer dyspepsia, for functional dyspepsia. You don't have to repeat the endoscopy because there is nothing that you need to see, already you have seen. Whereas in peptic ulcer disease, I would like to know whether the peptic ulcer has healed or for that reason. If it is not healing, then I should know what are the causes of non-healing, address those causes. One important cause is turning into malignant. Between the two, gastric ulcers turn more malignant than the duodenal. So, gastric ulcer, age is more than 55, the ulcer is not healing, rebiopsy is essential. Prokinetics, I told you there is only role for 4 or 5. Gastroesophageal reflux, hiatus hernia, diabetic gastropathy, and then motility reduced stomach, and functional dyspepsia. Other than that, you don't have to use the prokinetics left and right. Self-care after cure. Once you have treated, empower the patient to use the drugs on its own. This slide is a beautiful slide which summarizes the treatment of various types of dyspepsia. Uninvestigated dyspepsia. Who is this person? Less than 55, no alarm signs. I didn't put the endoscope. I started the treatment empirical. What do I give? Full dose PPI for 1 month, further PPI or H2RA for 1 more month. Not responding, then do the upper GI endoscope. NUD, non-ulcer dyspepsia. I have put the endoscope. There is no ulcer, but there is dyspepsia. Test for H. pylori and then treat. Low dose P, then followed by low dose PPI or H2RA for 1 month. No repeat endoscopy for non-ulcer dyspepsia. GERD, full dose PPI for 2 months, the longer treatment. Then double dose PPI for 1 month with plus or minus prokinetic, H2RA plus prokinetic. Do not combine PPA and H2RA. It is irrational combination to combine PPA and H2RA because PPA blocks the acid secretion. But whatever route it is there is no reason to give a separate H2RA. H2RA does what? How does it act? H2RA blocks the histamine. It is H2RA is histamine 2 receptor antagonist. Histamine, we have seen in the slide, is the promoter of acid. And H2RAs block histamine only, whereas PPI blocks all the other mechanisms. When you are using PPI, there is no reason to give H2RA. And if the GERD is not responding after 2 months or 3 months, then review diagnosis. And then if there is hiatus hernia, there are possible treatments, surgical treatments for hiatus hernia. There are 2 types of hernia, sliding type of hiatus hernia. These hernias must be surgically addressed. PUD, when you have a peptic ulcer disease, you must treat for H. pylori because H. pylori is a common offender for PUD, peptic ulcer. Even if the test is negative, you give an empirical treatment for H. pylori in PUD. And then full dose PPI for 2 months plus 1 more month, reduce all NSAIDs. Misoprost can be used. Misoprost is a prostaglandin promoter which will increase the mucosal immunity, and then PUD will heal. Repeat endoscopy is required after 8 to 12 weeks of treatment for PUD. This is to know whether the ulcer has healed or not. The ulcer did not heal. Review all the conditions of non-healing ulcer causes like Jollinger syndrome, MEALT, and all other rarer causes also. You need to MEN1. Those things you have to exclude. Functional dyspepsia, anti-anxiety drugs, or the antidepressant drugs, and then H2RAs for 1 month, antidepressants here. First one is AA is antacids. Antacids plus H2RA and add an antidepressant and behavioral treatment. also you have to consider. Okay, UID, NUD, GRD, PUD, FT. Malignancy we are not listed here. If you find there is a mass or an ulceration suggestive malignancy, take a biopsy and accordingly refer the patient to a surgeon because it is no more a medical problem. It has to be dealt by a gastroenterologist surgeon. So it's important here to early diagnose cancer early and put them onto treatment early. Okay. Now, from 1970s to 2025, there is a paradigm shift in our approach to treatment of dyspepsia. No ulcer, no acid, no ulcer. That's what earlier they were thinking. Acid is the only cause. Now we know acid plus pepsin and decreased difference is the cause. Then they were thinking acid, ulcer, acid, ulcer. Now acid alone is not the cause. Acid and pepsin from the GI tract, stomach, and decreased mucosal defense are the causes. Hurry, curry hypothesis was very prevalent when we were students. Now that has been ruled out. Obesity, lower esophageal sphincter is not working properly, excess fat intake, and smoking are the causes now. Then we used to do fractional test meal. What is fractional test meal? Give him a gruel, barley, in the morning on empty stomach. After the barley is given, rice tube is already in place. We used to draw acid content, gastric contents every 10 minutes and then titrate them under the burette and pipette and then see how much acid is there in that. This I have done several times. I used to do at least weekly once or two FTMs. FTM posted, Dr. Sarma on duty. So as a postgraduate, I used to go there. That's why I'll come at 6 o'clock an empty stomach, put the rice tube, give him barley, for every 5-10 minutes, you start drawing with the syringe, collect it, and then burette pipette, there will be acid titration. And once we know how much acid is there, note down and draw a graph. Now FTM is a forgotten story. You don't require to know about it. Barium series was the only imaging studies we have got. Every patient with stomach pain, barium's paste is there. Paste you mix it up, ask them to swallow. The barium goes through the GI tract. Take pictures at 5 minutes, 15 minutes, half an hour, 2 hours, 6 hours, 12 hours, 24 hours. All the GI tract follow the barium. And then indirect Sarma is, it could be ulcer, it could be that. No one knew gastritis, H. pylori, no one knew chronic gastritis, except a little indentation, ulcers and all that. That is gone. Very good for all of you. You don't have to do FTMs and bariums. Now what has come? Esophageal manometry. Now you have to, this manometry again gives esophageal pressure, esophageal acidity, it will tell you. And then pH meters have come directly into the stomach. Urea breath test has come, a radioactive capsule you have to give. Earlier we used to give no H2RAs, no PPIs, only antacids and not responding surgical. Gastrojejunotomy, vagot. Now PPIs, H2RAs, antacids have a limited role. H. pylori is not considered at all in those days. H. pylori is the culprit today and we have to test and treat. Peptic ulcer disease, carcinoma stomach is very much more. Now, peptic ulcer disease is replaced by GERD, functional dyspepsia, carcinoma of the esophagus, adenocarcinoma. Earlier it is carcinoma of the stomach because of the gastric ulcer, peptic ulcer disease, carcinoma of stomach were the common things. Today, carcinoma of stomach is replaced by GERD, functional dyspepsia, adenocarcinoma, Barrett's esophagus, and all those. Now, NSAIDs were not considered at all to have that they were playing a role. There were not many NSAIDs also. At the most, Brufen was there. No other drug, diclofenac and all were not there. And we had only aspirin and Brufen and paracetamol. We used to give Brufen and that was not considered. NSAIDs have a central role for treatment of ulcer healing. Stopping NSAIDs is very essential. That's why a paradigm shift has occurred from 1970s to 2020s in this 50 years. A long way we came from antacids to antibiotics for H. pylori, from antacids to antibiotics. Now it's an infection now to treat. So very important information. condition. I'm going to show some wonderful atlas. This is from the endoatlas.com. If you have a time, you can go to endoatlas.com, where most of the endoscopic pictures are posted there. I have sampled some of those pictures for you. Now you see, that is the normal stomach on the left-hand side, and a close-up view of the rugosities. Stomach will have all those folds. Why folds? Normally stomach is on this side. When you take food, it has to expand, and the folds are there. The rugosities help the stomach to expand when you take food. So the normal stomach and the rugosities of the stomach. Now, candidal esophagus. You see the the curved-like appearance, curved flakes-like appearance. You can see on the distal esophagus and proximal esophagus. Very common in diabetics. So candidal esophagus on the other side, lower end. This is in the mid esophagus on the left side. If you see candidal esophagus, you have to treat them with parenteral antifungal agents and investigate thoroughly for diabetes and manage the diabetes. Candidal esophagus is very painful, and then dyspepsia is a very distressing symptom for. Even if you get little candy in the mouth, you know how painful it is. Candidal esophagus is a very painful condition. Now, you see completely ruddy esophagus there. That is the gastroesophageal opening there. Chronic GERD, the Barrett's changes, and then the metastatic, the columnar epithelium as metaplaced there, and then you see the Barrett's esophagus, and then the two pictures of severe Barrett's esophagus, which are the end result of chronic GERD. Then there is a retained tablet in the esophagus. This fellow has got dyspepsia, tablet could not go through. We have found out that adenocarcinoma, you can see on this picture, there is a bulge in the inferior lateral wall of the esophagus, and that is in the 7 o'clock position. You can see the bulge. That is when biopsied, it was adenocarcinoma. So NSAID ulcers look like that. They will be very red in color. Number is 5 to 6, spread all over. NSAID ulcers look like that. NSAID ulcers will have some slough also. It is not pan-gastritis. It will be like this. Okay. Now, H. pylori ulcers. So I was telling about H. pylori, salt and pepper appearance. This is also a close-up view of the salt and pepper appearance. A diffuse appearance with red and white spots. When you see such picture, you have to suspect H. pylori and immediately do the test for the antigen test for the H. pylori. So this is the gastric ulcer with slough there, sitting on the greater curvature of the stomach. This is on the stomach, the fundus of the stomach. Gastric ulcer is there. And then gastric ulcer, a chronic gastric ulcer with slough there in both the pictures. Now you have got the duodenal ulcers. Between the two gastric ulcers are more malignant. Duodenal ulcers are easier to heal. Gastric ulcers are difficult to, because gastric ulcers are less exposed to the acid. Duodenal ulcers are less exposed to the acid and pepsin. So the duodenal ulcers heal faster compared to gastric ulcers. But the problem with duodenal ulcers, duodenal ulcers, when they heal, they produce cicatrization and obstruction. It can lead to duodenal obstruction. And I had several patients of duodenal obstruction when we were students. Today, we don't see one patient of duodenal obstruction because of the PPIs and modern management of dyspepsia. Okay, this is adenocarcinoma and fungating and opened up adenocarcinoma on the other side. Now, carcinoma of the stomach, you can see the carcinoma of the stomach is there. Carcinoma of the duodenum, you can see this. These are some of the endo pictures. And now time trends in upper GI cancer. What is happening? You see, 1930 to 2010, the x-axis is 1930 to 210. You can see the lower line. The lower line is adenocarcinoma. Until 1970, adenocarcinoma was very low. Now, the adenocarcinoma is increasing, and it is the most important cancer in the upper GI tract, adenocarcinoma. Whereas, if you see the second line, which is the squamous cell carcinoma. Squamous cell carcinoma was very high to start with, but slowly the squamous carcinoma, after 1975, with the advent of PPIs, it is coming down. Squamous carcinoma is coming down, adenocarcinoma is going down. Carcinoma of the stomach used to be very important condition in early 80s and 90s, from 2000 onwards. Once you have got the H. pylori treatment available and the PPIs are available, prokinetics are available, ulcers are better treated, patient is improving so much, this carcinoma of stomach is showing a downward trend. So carcinoma of stomach is coming down, adenocarcinoma is increasing, squamous cell carcinoma rather decreasing. So this is the time trends are also important. Now, why do a physician misses carcinoma of the upper GI tract? Why? Why a physician is missing? We don't want to miss cancer. The entire exercise is to prevent you from missing important cancers. 2.8% of dyspepsia have cancer. 25% of the cancers have no alarms. We are filtering them by alarm signs. But 25% of them, they don't have alarms. They don't have dysphagia, they don't have bleeding, they don't have anemia, they don't have loss of weight. 25%, only 70%. At least if you screen, 70% you can identify. Remaining 25% is not having alarm symptoms. If those with alarm symptoms also, only 68% have cancer. Endoscopy is not appropriately used. Endoscopy is delayed or not done even after 8 weeks of treatment. There is no point in waiting, and patient will refuse. He will say, give me tablet, I don't want tube, it is painful. But we have to motivate the patient, and you can anesthetize also. In a very anxious patient, you can give a short injection, midazolam or something, and finish that. Okay, endoscopy is not inappropriate. H. pylori is not considered at all. Another reason, H. pylori should be considered. Medications are not reviewed. NSAIDs are not stopped. Ulcerogenic medications are continued. Alarm signs, urgent endoscopy is not done. The last one is, give me tablet, don't put the tube. Matrai kudunga, pipe vandam. In Tamil, it means, give me tablet and don't put the pipe. That was the general patient. That is why we miss gastric cancers. So that ends the today's talk. 3:30 correctly. Yadyadacharati shresthaha tattade vetaro jana sayat pramanam kurte lokastad anuvartate. Means what? My dear learned intellectuals and stalwarts of society, please be aware, whatever you do, you practice, is being keenly observed by the common man. Yadyad acharati shrestha. The shrestha people there, people like educated persons like us, and teachers and doctors and professors and engineers and software people, whatever they do, the businessmen, the others will copy. So we have to set a benchmark. They take you as a benchmark and then simply copy whatever you do. So if your behaviors are good, we expect the population also to behave. So the onus is very much on you, sir, to set yourself the highest standard, be a role model. To do. This is the teaching of Bhagavad Gita, where Krishna is telling Arjuna, Yajyadacharati shresthaha tattade vitarojana sayat pramanam kurute lokasta dhanvartate. Arjuna, if you run away from battlefield, if you run away from responsibility, others also will Xerox copy it, they will also run away from responsibility. So be aware of this and act wisely. He was advising. The same thing is true to all of us. Okay.